Hello doctors, very good evening to all of you. So let's complete PEDS today at least. So we have to start with this infectious diseases. A 6-month-old infant is brought in by his mother after what she described as a seizure. The child has had a fever of 38 degrees centigrade, that is more than 100.3 Fahrenheit for the last 3 days, and has been very irritable lately. He appears unresponsive but is breathing. Physical examination reveals a markedly delayed capillary refill and a blood pressure of 80 by 20 mmHg. So he's just 6 months old. He's presenting with a fever that is 38, that's more than 100.3 Fahrenheit for the last 3 days. And on physical examination, this baby has markedly delayed capillary refill and a blood pressure of 80 by 20. Now, what is the most likely diagnosis? Because he's having seizure with high-grade fever, so definitely this will be a case of febrile seizure. This child has febrile seizure secondary to sepsis. The real take-home message with this, the real just one second. Yeah, the real take-home message with this case is to evaluate the child for the underlying cause of the sepsis. So we have to evaluate what is the cause behind the sepsis. Understanding he has had a febrile seizure is only the surface of the case. A full sepsis evaluation must be ordered. We have to go for the full evaluation of the sepsis, which include we'll go for the CBC with differential blood, we'll check the urine cultures, we'll do the urinalysis, we'll perform the chest x-ray and lumbar puncture if irritability or lethargy is mentioned. So if there is a point of lethargy or irritability in a VNet, then go for the LP test also, because we need to rule out meningitis in that case, in that particular case. Dog bites do not present with seizures. So there's an option here with the C, that's dog bites. So of course dog bites do not present with seizures. We'll not go for that choice. And cocaine withdrawal does not have seizures as well. So we'll not go for the cocaine, we'll not go for the epilepsy. The clear diagnosis here with febrile with high temperature 38 degrees centigrade or more than 100.4 Fahrenheit is the case of febrile seizures. Now we have neonatal sepsis. So what are the most common causes of sepsis? If we consider it's sepsis maybe because of most common causes are pneumonia and meningitis, in which the baby can go into sepsis. And most common organisms, this is very important for our exam point of view, most common organisms are group B strep, E. coli, Staph aureus, Listeria monocytogenes, right? So they are considered to be the most common organisms which are responsible for creating sepsis. Now for the diagnostic testing, we have blood cultures and urine cultures. We'll go for the blood culture, we'll go for the urine cultures, we'll perform the chest x-ray, right? And for the treatment option, we have ampicillin and gentamicin. So ampicillin, gentamicin will cover all the gram-negative inroads, right? So this is a good choice for sepsis. Now we have this algorithm with us. This is the neonatal sepsis onset and treatment. So we have early onset and we have late onset. If it's early onset, then we should always consider group B strep infection or E. coli or Listeria should be in our mind. And for that, we have to go give intravenous fluid. We should do cultures, we'll provide antibiotics, right? And what sort of antibiotics we will give? We'll give ampicillin, gentamicin, and cefotaxime. So cefotaxime, gentamicin, ampicillin are the choices for antibiotic in case of E. coli, group B, or Listeria infection that is actually occurring as an early onset. But if there is late onset, we should always consider staphylococcal infection. E. coli is common in both, and group B strep. But group B strep is on the last priority. The first priority we're giving with this to this staphylococcal infection, right? So again, we will go for the intravenous fluid administration, we'll do the cultures, we'll give antibiotics. And what sort of antibiotic? That's the same thing, ampicillin, gentamicin and cefotaxime. So the treatment is same for both the cases, whether it's an early onset or if it's a late onset. So this TORCH is an acronym of toxoplasmosis, or for other infections such as syphilis, or for rubella, C for cytomegalovirus, and H for herpes simplex virus. So these are all the infections which are actually creating an acronym named as TORCH. So TORCH infections, now we are dealing with each infection separately. What is the presentation, what are the diagnostic testing we are going to offer, and what particular treatment we are going to give to this patient. Say for example, if it's a case of toxoplasmosis, so how toxoplasmosis is going to occur? The presentation will include, there must be a presentation of chorioretinitis, there must be hydrocephalus and a multiple ring enhancing lesions when you do the CT. And which organism especially cause these lesions? That's a specific one, that is Toxoplasma gondii. So Toxoplasma gondii is one of the infection that can cause multiple ring enhancing lesion, especially in a case of toxoplasmosis. Now, for the diagnostic testing, the best initial test is elevated IgM. So you will see this immunoglobulin M, which is elevated here, and this is considered to be the best initial test. We should know what are the initial testing and what are the best initial and what are the most accurate tests, right? So here it's mentioned best initial test is elevated IgM to toxoplasma, and most accurate test is polymerase chain reaction for toxoplasmosis. So PCR for toxoplasmosis, that is considered to be the most accurate one, and best initial is IgM. Now for the treatment option, we have pyrimethamine and sulfadiazine. So we'll give pyrimethamine and sulfadiazine for the treatment of toxoplasmosis. Then we have syphilis. Syphilis, the presentation is very common. There are rashes on the palms and soles and snuffles, and there are frontal busing and Hutchinson 8 nerve palsy, especially here in a case of syphilis patient, and saddle nose. So presentation is quite obvious in case of syphilis, so you can easily rule out on the basis of physical examination, on the basis of presentation of this particular disease. There are the rashes, the busing, frontal busing, nerve palsy, that's 8 nerve palsy, and saddle nose. These are the common features. Now for the diagnostic testing, we'll go for the best initial test. Best initial test is VDRL or RPI testing. Most accurate test is FTA, that is fluorescein treponemal antibodies testing or dark field microscopy. So VDRL or RPR is considered. You should know that what is the initial best initial and what is the most accurate for syphilis. So best initial is VDRL or RPR testing, but most accurate is fluorescein treponemal antibody testing, that's FTABS or dark field microscopy. The dark field microscopy or FTABS, this is the most accurate one. And what's the best initial one? VDRL or RPR. Penicillin you have to go for the treatment option. Then we have rubella. Rubella can present, like the baby can present with this patent ductus arteriosus, right? And cataract, because there's a congenital infection, so baby must be having PDA, baby must be having cataract, there's stiffness, there's hepatosplenomegaly, the baby must be having low platelet count, that's thrombocytopenia, there is blueberry muffin rash, very peculiar, very specific for rubella, and of course hyperbilirubinemia. So these are the particular presentation for rubella infection, for the congenital infection of the baby especially, and they actually got this infection during pregnancy. The mother got the infection and the baby is infected and having all these presentation. Now we will do the maternal IgM status. We'll check the maternal IgM status along with clinical diagnosis. So clinically we have to diagnose, we'll check the maternal IgM, and each disease manifestation must be individually addressed. We have to address each particular individual manifestation we have to go for. Supportively you are providing the treatment. Now for the cytomegalovirus infection, there must be periventricular calcifications on presentation with microencephaly. So microencephaly, the short hair with peripheral ventricular calcification, that's important presentation. There must be chorioretinitis. Chorioretinitis, remember, that's also the first point here in toxoplasmosis. The same presentation here in cytomegalovirus infection. Hearing loss and petechial rashes. So petechiae, the small bruises, the rashes, they are here in case of cytomegalovirus infection. The periventricular calcifications, the short hair, microencephaly, chorioretinitis. These are all the features of cytomegalovirus infection. Now, what you're going to do, especially for the diagnostic testing, that best initial test is urine or saliva viral titers, but the most accurate test is urine or saliva PCR for viral DNA. So initially, best initial is you can either go for the urine viral titers or saliva viral titers, right? But the most accurate test is PCR testing, that's a polymerase chain reaction for viral DNA, especially in case of cytomegalovirus infection. Now for the treatment option, we have this Gansey clover with signs of end organ damage. Whenever there are signs of end organ damage, we have to go for the treatment of this Gansey clover because it's a virus. Then we have herpes. Herpes presentation in week 1, in week 2, in week 3. It's divided into 3 weeks presentation. We have a herpes especially. So week 1 is presenting with shock and DIC, disseminated intravascular coagulation and shock of present, this is the first presentation in week 1. In week 2, the baby must be presenting with vesicular skin lesions. In week 1, there must be signs of shock and signs of DIC. In week 2, there are signs of vesicular skin lesions. And in week 3, the baby is going to present with encephalitis. So shock and DIC leading to vascular skin, and last but not the least, encephalitis will develop in this case. For the diagnostic testing, we have best initial test, that's Zank smear. We'll go for the Zank smear testing, and for the most accurate, we have to go for PCR. You have noticed that right from the beginning, the most accurate test is PCR of that particular infection. So in general, we can memorize the PCR we have to go, especially in only except in a case of syphilis, because for syphilis we have this FT, field microscopy, dark field microscopy, which is considered to be the most accurate test. And of course for the rubella we don't have PCR, but other than that, for toxoplasmosis we have PCR, for CMV, cytomegalovirus we have PCR, for herpes we have PCR, right? Now coming towards varicella. So the other viral childhood illness is varicella. So etiology, of course, is varicella infection. That's Zoster virus infection. So now they are the viral childhood illness. So first we are dealing with the torch infections, right? These are the torch infections. Now we are coming towards the viral childhood illness. In viral childhood illness, we have varicella, we have Ebola or measles, we have fifth disease or erythema infectiosum, we have roseola, and we have mumps, right? So these are considered to be the viral childhood illnesses. So first of all, we are going to deal with varicella. We should know the etiology of varicella. Of course, it's caused by varicella zoster virus. Presentation, the baby must be presenting with multiple highly pruritic vesicular rash that begins on the face first and possibly fever and malaise. So rash which is actually starting on the face associated with fever and malaise, that is the main presentation of varicella infection. Now how you are going to diagnose these patients? Your best initial test is Zank smear showing multinucleated giant cells. Most accurate test is viral culture. So this is important to remember. The best initial testing is Zank smear, but the most accurate test is viral culture. We have to provide the supportive treatment with topical ointment. We have to give topical ointment. We have to provide supportive treatment in case of varicella infection. Then we have this rubella or measles. Of course, the causative agent is paramyxovirus, and there are, for the presentation, the 3 C's are very common for this rubella or measles infection, and 3 C's are number 1 cough, number 2 coryza, and number 3 conjunctivitis. So cough, coryza, and conjunctivitis, these are the 3 main or most important presentation in measles, associated with conjunctivitis with a cup-like spot, that is a grayish macule on buccal surface. So grayish macule on buccal surface, that's an important thing. That's a cup-like spot. Conjunctivitis, associated conjunctivitis, and coryza and cough. So 3 C's with a cup-like spot is the presentation for rubella, the measles. So clinical diagnosis, of course, we have to diagnose it clinically, and most accurate test is measles IgM antibodies. If you go for the IgM antibodies for measles, and if it's a positive, so definitely that's the most accurate test. Of course, we have to give supportive treatment to these patients. Mostly viral infections need supportive treatment, right? Then we have fifth disease or erythema infectiosum. The parvovirus B19 is the main responsible particular organism for fifth disease, and presentation starts with fever and upper respiratory tract infection and progresses to rash with slapped cheek appearance. So it's a, with a fever, with upper respiratory infection symptoms, and slowly progressing to a rash which is having a very peculiar appearance, that is a slapped cheek. So this is slapped cheek word is associated with infectiosum, erythema infectiosum. You have to diagnose it on the basis of clinical assessment, and supportively you have to treat your patient. Now we have roseola. Roseola is caused by herpes virus type 6 and 7. presenting with fever, upper respiratory tract infection, same like fifth disease, but progressing to diffuse rash. Here you are not going to see a slapped cheek, rather you are going to see a diffuse rash. So if it's a diffuse rash, it's a Gaziola. Clinically, you have to diagnose and you have to give supportive treatment. Then we have mumps. Mumps is caused by paramyxovirus, and it's actually the presentation is fever, precedes classic parotid gland swelling with possible otitis. That's very important point, possible otitis with this parotid gland swelling. So parotid gland swelling and possible otitis, these two things are very important findings in paramyxovirus, which leads to mumps, and clinically you have to diagnose and definitely you have to provide supportive treatment. So what we can see that most of the big viral infection, we have to diagnose it clinically and we have to provide nothing but just a supportive treatment. Now the question says, a 5-year-old boy is noted to be fatigued and lethargic in class. High school teacher observed that he has a beefy swollen tongue, and the school nurse calls the office because he is febrile. So it's very important, history. Febrile, beefy swollen tongue. The nurse says the boy's skin feels porous like sandpaper. The third thing, sandpaper skin, and his tongue looks like a strawberry. The very important finding, upon examination, you find that the child's rash blanches easily and there is no desquamation of the lips. So there is no desquamation, the child's rash blanches. That's an important thing. Strawberry tongue, beefy swollen tongue, and lethargic, fatigue, the 5-year-old boy, these are all the features which we have to make a note in order to make a diagnosis. Now, question asking you that which of the following is the next step in the management of this patient? What you are going to do next, right? So, on the basis of the features of a child, first we have to create a diagnosis, a differential diagnosis, a provisional diagnosis in our mind, and then we will select the answer choices accordingly. So, this is a case of scarlet fever. So if it's a case of scarlet fever, that's an infectious disease case. So our next step in the management of this patient should be start antibiotics. See, penicillin is the next best step in the management of this patient because scarlet fever, which is the diagnosis here, is an infectious disease caused by Streptococcus pyogenes, and that presents with sore throat, strawberry tongue, which is the case here, which is the symptom mentioned here as well, and a sandpaper-like rash that blanches easily. It's also there in the V-net. The rashes in the inguinal areas and axillary folds of the body are known as pastillines. So these pastillines, these are actually the rashes in the inguinal areas and in the axillary folds. So the complications are acute rheumatic fever. If you don't start antibiotic at once, then what will happen? It can lead to acute rheumatic fever and there will be glomerulonephritis subsequently. So these are the complications. So in order to prevent your patient from getting into complications, we have to start antibiotic, and that should be your next step in the management of the scarlet patient. Immunoglobulin does nothing for scarlet fever. ESR is too non-specific to be helpful. So these are not the things. We are not going to waste our time in doing cultures right now. We cannot just only observe the patient. Rather, we have to start antibiotic immediately in order to prevent complications in your child. So now I'm going to deal with the scarlet fever in detail. The scarlet fever is the diffuse erythematous eruption that is concurrent with pharyngitis. It is caused by erythrogenic toxin made by Streptococcus pyogenes and typically lasts 3 to 6 days. That is very important for the scarlet fever, the time period lasting for 3 to 6 days, right? Now for the presentation, scarlet fever present with a classic pantade. There are 5 things which we have to make a note in case of scarlet fever. The patient must be presenting, as the name says, scarlet fever. The fever should be there. There must be pharyngitis, the sandpaper rash over trunk and extremities, strawberry tongue, and cervical lymphadenopathy. Cervical lymphadenopathy, please do remember this point. Strawberry is there, fever is there, rash is there, pharyngitis. So these are all the presentation. That's a classic pantade. Now for the diagnosis and the treatment, the diagnosis of scarlet fever is made clinically. However, it can be correlated with an elevated anti-streptolysin O titer. So we can go for the ASO titer, we can go for the ESR, we can go for the CRP. All of these things will show you about the infectious rate, and treatment is with penicillin, azithromycin, or cephalosporins. So penicillin, azithromycin, cephalosporin will be the treatment option. That's our broad spectrum antibiotics, right? Beta-lactam antibiotics as well, macrolides as well, and for the treatment, especially for the treatment. And for the diagnosis, we have erythritida, ESR, and CRP. We're coming towards malignant otitis externa. Malignant otitis externa is an invasive infection of the external auditory canal, because the word says otitis externa. So if the word says otitis externa, it should be the infection of the external auditory canal and skull base due to Pseudomonas aeruginosa. It's very important to remember the name of the organism. It's very important. So here the organism is Pseudomonas aeruginosa. Patients with malignant external otitis classically present with exquisite otalgia and otorrhea. So presentation is very important as well. So organism is Pseudomonas aeruginosa, and those who are having malignant external otitis, they must be present with in combination of otalgia, this ear pain, and otorrhea. Particularly this fluid, and especially maybe this CSF coming out from the ear, that's otorrhea. So otorrhea and otalgia, these two are also important in case of malignant external otitis. Now, point to ponder here is topical therapy is always wrong for malignant otitis externa. We will never give topical therapy. This is the most common wrong answer. We should not choose that topical therapy for the treatment of malignant otitis externa. Now, the best initial test is CT scan of the skull base. See, that's very important. This is considered to be the best initial, but the best one is CT scan of the skull base. Why? Because this skull base is actually involved. This external auditory canal is actually involved with the infection of the Pseudomonas aeruginosa. So we have to check the skull base. We'll go for the CT scan. Biopsy is the most accurate test, which we usually don't do. We will only prefer CT. Ceftazidime is an anti-pseudomonal drug that is often used in children with malignant otitis externa. So we usually use ceftazidime for especially in children who are having malignant otitis externa. So we'll go for this because this is the most useful anti-pseudomonal drug. You remember when we did the infectious diseases, pseudomonal coverage was very low, right? So the ceftazidime is considered as for anti-pseudomonal drug. So we will give here. Now we are coming towards retropharyngeal abscess. Retropharyngeal abscess are deep neck space infections because of their potential for airway compromise and other catastrophic complications. They can pose an immediate life-threatening emergency. The most common cause is group A beta hemolytic streptococci. So the most common cause of retropharyngeal abscess especially is a beta hemolytic streptococcus. This you have to remember, and they can pose an immediate life-threatening emergency. That's also a very important point. Look for a patient with a decreased or painful range of motion of the neck or jaw. Your patient is not producing motion of the neck or jaw, and there is very painful range of movement, and some patients may present with a muffled hot potato voice and deviated uvula. So these words, hot potato voice, deviated uvula, they are very specific for retropharyngeal abscess. Must remember, hot potato, deviated uvula for the retropharyngeal abscess. CT of the neck can distinguish between an abscess and cellulitis. Incision and drainage of the abscess is the best therapy. So we'll go for the IND. The fluid should be collected and sent for culture. While waiting for the culture results, we just can't wait only for the culture result. We have to empirically administer some antibiotics. So we are giving the safe combination here, that is ampicillin and sulbactam combination. But later on, we will change the antibiotic according to culture's result. Alright, now we are going to start pulmonary diseases. Now, the vignette says a 2-year-old child is brought in for a severe cough, fever, and runny nose. The cough sounds like a barking cough strikes in your mind. And she is in obvious respiratory distress. She is just 3 years old. Upon physical examination, she refuses to lie flat. Chest X-ray shows a positive steeple sign. Barking cough, steeple sign. These two important things are here to think of you that what is the diagnosis here, what is the most appropriate next step in management. First you should make a provisional diagnosis and then you decide accordingly what should be the most appropriate next step in the management. Either you are going to intubate the patient, or you will give racemic epinephrine, or you will give empiric antibiotic, or acetaminophen, or CT-NAC. So actually this is a case of upper respiratory tract infection, because the barking cough is there, right? And this X-ray finding steeple sign is very particular. So for the child present with classic signs of croup, this is a case of croup, right? Because barking cough, the word barking cough and croup X-ray usually shows steeple sign. So the steeple sign for the croup chest X-ray and this barking cough for the croup is, these are actually the classic signs of croup, barking cough, inflammation. The child presents with classic signs of croup and inflammation that is quite literally choking of the upper airway. The C-like barking cough with upper respiratory tract infection like symptoms give its way away, and this is a medical emergency. Remember, this is not a surgical emergency. Epiglottitis is considered to be the surgical emergency, but this croup is a medical emergency. For that we have to give empiric, this racemic epinephrine for emergency, for medical emergency. Now, to prevent asphyxiation and probable tracheostomy, administer racemic epinephrine to decrease swelling, because we want just to decrease the swelling, and it's a medical emergency, so we will give racemic epinephrine. Why? Because we want to prevent asphyxia and we want to prevent tracheostomy in this case. Do not waste time with the radiology, do not send your patient anywhere, and there is no medical evidence suggesting that intubation or antibiotics or antipyretic decreases mortality. Of course, we will provide these medication as well, but they are not going to decrease the mortality of your patient. So here they are asking you what is the most appropriate next step in management. So it's a case of medical emergency, you have to give something in emergency, and that's racemic epinephrine, which is definitely going to slow down the process of inflammation. Now we are dealing in detail about the croup. Croup is an infectious upper airway condition. It's an upper airway infectious condition characterized by severe inflammation. So there is severe inflammation here, and it is most commonly caused by which virus? Parainfluenza virus type 1 and type 2. Respiratory syncytial virus is the second most common cause. So it's definitely RSV is also cause of croup, but we have to remember who is the first one. That's parainfluenza. And parainfluenza has two types, type 1 and type 2, and RSV is the second most common. Now, how your patient is going to present? Who present with barking cough. This barking cough is very, very, very particular for croup, and coryza and inspiratory stridor. Again, inspiratory stridor is very much associated with croup. So, a stridor during inspiration plus barking cough, coryza, this these are the findings in your children, and the child will have more difficulty breathing when lying down and may show signs of hypoxia such as peripheral cyanosis and accessory muscle use. Your child should be using accessory muscle for respiration, and peripherally he must be cyanosed, and when he lies down he is having difficulty in breathing. The chest X-ray will show the classic steeple sign, that's very classical, very pathognomic for X-ray finding in croup, a narrowing of the air column in the trachea. So because of the narrowing of the air column in the trachea, this steeple will come up like this. However, X-ray is rarely done and is always the wrong answer to the most appropriate next step. We will not go for the X-ray, right? This is considered to be the wrong answer. Chest X-ray will show the steeple sign, but don't waste your time, right? You should go for the medical emergency treatment. Now, for the diagnostic test and treatment, the diagnosis is made clinically and can be aided by radiology. If the symptoms are mild, then only you will go for the radiology. Hypoxia aids in differentiating croup from epiglottitis. For mild symptoms, give steroids. If they're the mild symptoms, you will go for the steroids. But for the moderate and severe symptoms, you have to give racemic epinephrine. So remember, for moderate and severe symptoms, we have to go for the epinephrine. But for the mild, we can just provide steroids as well. So croup is equals to hypoxia in presentation. Definitely, whenever you see hypoxia on presentation, that's a case of croup. But when there is hypoxia imminent, right, that is a surgical emergency, and that is epiglottitis. So there's a marking difference between croup and the epiglottitis. Croup is hypoxia on presentation, while epiglottitis is hypoxia imminent. So that's a croup is a medical emergency, while epiglottitis is a surgical emergency. A question says a 4-year-old child is brought in because of extreme irritability and refusal to eat. He refuses to lean back, speaks in muffled words, looks extremely ill, and is drooling. Chest x-ray shows a positive thumbprint sign. So this positive thumbprint sign is very peculiar for epiglottitis. The baby is drooling, baby looks extremely ill, muffled words, refuses to lean back. This is surgical emergency. You have to intubate your patient right then. Don't waste time, right? So what is the most appropriate next step in the management? The most appropriate step will be to intubate that child who is having all these problems, right? This child presented classic signs of epiglottitis, the truest medical emergency in pediatrics, right? He must be intubated at once. Do not waste time with anything else, including a full examination. Don't even go for that, as his airway may close off any minute. So every minute counts, right? Now, purists even say to avoid startling the child, this case mention a thumbprint sign to aid your studies. Just to give you a clue that that thumbprint sign is there, just to give an idea that this is a case of epiglottitis. But chest x-ray is really done with such a convincing presentation. Don't waste your time in doing x-ray, right? Just intubate your patient. The remaining choices are not indicated until airway management is conducted, and remember your ABCs, right? Now, foreign body aspiration. Foreign body aspiration is most common in children aged 1 to 3 years who present with a sudden onset of respiratory distress without a preceding illness, of course. And the most common location for the aspirated object to lodge into is the right main stem bronchus. So, right main stem bronchus is a side where most of the objects can lodge. The most frequent symptoms are choking and sudden onset of respiratory distress. Physical exam will show focal monophonic wheezing with diminished air movement on the affected side. However, a chest x-ray is the best initial diagnostic test because about 2/3 of aspirated objects are radiolucent. So that's why we have to go for the chest x-ray. That is considered to be the best initial one. Immediate rigid bronchoscopy is both the most accurate test and the appropriate treatment. Now, we will go for the immediate rigid bronchoscopy. So first the chest x-ray and then bronchoscopy. That is considered to be not only the most accurate test, but the treatment also. Alright, so we are dealing with the epiglottitis in detail now. Epiglottitis is a severe life-threatening swelling of the epiglottis and arytenoid cartilage due to Haemophilus influenza type B. So that is the most important etiology. Haemophilus influenza type B is responsible for creating this epiglottitis. So look for a child with a history of vaccination delinquency, with a child who's having a hot potato voice, a child who's having fever, drooling in the tripod position, refusal to lie flat. So hot potato voice, fever, drooling, refusal, these are all the presentations of epiglottitis. Physical examination will reveal an extremely hot cherry red epiglottitis. See, it's very important physical examination, extremely hot cherry red epiglottitis. For the diagnostic testing and for the treatment plan, diagnosis is made clinically, but X-ray may reveal a classic thumbprint. So X-ray findings are important. For the croup, there was steeple sign. For this particular epiglottitis, we have thumbprint sign to treat. You have to intubate your patient. The child in the operating room, the OR, is the preferred setting in case of unsuccessful intubation, makes tracheostomy necessary. Why we want to intubate a child in operating room? Because if there is need of tracheostomy, we don't need to rush anywhere else. We are just in the operating room and we can perform tracheostomy as well. Now, administer ceftriaxone. We have to give antibiotic for 7 to 10 days, and rifampin must be given to all close contacts. It's for prophylaxis for the contacts. So, rifampin must be given to all close contacts. Now we're coming towards whooping cough. Whooping cough is a form of bronchitis caused by this Bordetella pertussis presentation. There are 3 stages in case of whooping cough. First is catarrhal stage, paroxysmal stage, and convalescent stage. For the catarrhal stage, there is severe congestion and rhinorrhea. Rhinorrhea, CSF is coming through the nose, there is severe congestion, and that's lasting for 14 days. So 14 days in duration. That's the first 14 days. Congestion, rhinorrhea. Then we have paroxysmal stage. Paroxysmal stage is severe coughing episode with extreme gasp for air. So there is extreme gasping for air, for especially air, and there is severe coughing, right? Followed by vomiting, and this is lasting for the next 14 to 30 days in duration. That's inspiratory whoop particularly. And for the next stage, that's a convalescent stage, decrease of frequency of coughing in the later 14 days in duration. So all these stages are a 14 days incubation time period, duration time period. But what is actually happening in catarrhal, there is congestion, there is rhinorrhea. In paroxysmal, there is severe coughing, that's inspiratory whoop. But in convalescent stage, there is decrease of frequency of coughing. So that's a stage in which at this whooping cough is actually going to be an end, right? Now for the diagnostic test, we have clinically made diagnosis with whooping, inspiration, that's the second stage, vomiting and burst, so blood vessels in eyes, burst, blood vessels in eyes, vomiting, whooping, inspiration. That's how you are going to clinically diagnose your patient. Butterfly pattern on chest x-ray. Butterfly pattern. First one, thumbprint, steeple in the crew, thumbprint in the epiglottitis, and chest x-ray, butterfly pattern and whooping cough. So PCR of nasal secretions or Bordetella pertussis toxin, you can go for the ELISA testing, right? So PCR is considered to be the most accurate one because the polymerase chain reaction that can easily be done of nasal secretions, right? And or we can go for the ELISA testing as well. For the treatment option, erythromycin or azithromycin, both the macrolides, aids only in catarrhal stage, not in the paroxysmal stage, right? Only in the catarrhal stage we will give macrolides. Isolate the child. Macrolide must be given for all close contacts. We have to give, macrolides to close contacts as well. D-type vaccine has decreased incidence, so we have to give this vaccination to our children as well. Now, in order to summarize the upper and lower airway diseases, we have bronchitis, we have pharyngitis, we have diphtheria. So we need to summarize all these on the basis of etiology, what are the causes, what are the presentation, how we're going to diagnose, and what treatment we should opt for, we should provide. So for the bronchitis is caused because of various bacteria and viruses which actually cause inflammation of the airways. How they are going to present? The baby must be having a productive cough lasting for more than 7 to 10 days associated with fever. The baby must be having fever. There is a productive cough. So clinically you have to diagnose and definitely you have to provide a supportive treatment. Now for the pharyngitis, there is the inflammation of the pharynx and adjacent structures. So pharynx and adjacent structures, they are involved here, caused by group A beta hemolytic streptococcal infection. So group A beta hemolytics are responsible for pharyngitis. For the presentation, the baby must be having cervical adenopathy, there are the pedicle rashes, the fever is there which is above 40 degrees, that's more than 104 Fahrenheit. We have the upper respiratory tract infection symptoms. The complications can lead to acute rheumatic fever and glomerulonephritis. So pharyngitis and then rheumatic fever acute and then glomerulonephritis. You see the transition of this virus from one part to the other. Diagnosis, you have to go for the rapid DNA antigen detection test that you can do in office setting, OPD setting as well. For the treatment, we have to give oral penicillin. This is very important for exam point of view. You have to give oral penicillin for how many days? That's important. For how many days? For 10 days. Or macrolides for penicillin allergy. The one who is allergic to penicillin, you have macrolides. Macrolides include azithromycin, erythromycin, that you can give. Now we have diphtheria. Diphtheria, membranous, that's the etiology, that's the cause. Membranous inflammation of the pharynx due to bacterial invasion by Corynebacterium diphtheria. So there is bacterial invasion. The name of bacteria is Corynebacterium. As the name indicates, diphtheria, Corynebacterium diphtheria. Now, the gray, highly vascular pseudomembranous plaques on the pharyngeal wall, you will see. That's a very important presentation. That's a gray, highly vascular. Do not scrape this. That's very important. It's a plaque. Don't scrape it. Culture of a small portion of superficial membrane, that you can do for the diagnosis, and for the treatment you will give antitoxin. And remember, antibiotics do not work here. So we have to give antitoxin. That's an important point here. Okay, now we're coming towards seizures. Seizures classically present a subtle repetitive movement, the repetitive repetition of the movement, such as chewing or tongue thrusting or apnea, staring, blinking, desaturation. So these are all the repetitive movements, and they are actually the classic presentation of seizures. Tonic-clonic movements are uncommon. The overall goal is to uncover the cause of the seizure and treat it. How we can uncover that, yeah, there's a seizure, and how we're going to treat it. That's important. Now for the diagnostic testing, we have EEG, may be normal. CBC, electrolyte, calcium, magnesium, glucose, we can go for all the testing. There may be hypoglycemia, which is a common cause of seizure in infants of diabetic mother. That's important only for those infants whose mother are gestational diabetes, whose mother having gestational diabetes. So infants of diabetic mother or infants of gestational diabetes in mother especially, they are going to present with hypoglycemia. Rule out infectious causes. You have to rule out any infectious causes. You have to rule out torch infections. You have to do blood and urine cultures. You will do LP. If meningitis is suspected only, if there is confusion also, then this is encephalitis. But if it's only meningitis you are suspecting, signs of neurological deficit, you will go for the lumbar puncture. Now, ultrasound of head in preterm neonates to look for intraventricular hemorrhage. So, if you want to look for the intraventricular hemorrhage, then in preterm, especially in preterm neonates, we will go for the ultrasound of head as well. Other than that, we usually don't prefer for the ultrasound. But here, the ultrasound of head we will do if we are suspecting that our neonate is preterm and he is having intraventricular hemorrhage. Now, for the treatment, correct the underlying cause, including electrolyte abnormalities. For acute seizure, you have to use lorazepam or diazepam rectally. That's very important for our exam point of view. We should know the lorazepam and diazepam, they are considered to be the treatment for acute seizures. Treatment for chronic seizures depend on type with absent seizure. So you can use ethoxyzumide, but that for the chronic one. But for the acute one, must remember, it's also mentioned here, lorazepam and diazepam. Very important question for our exam point of view. Now we're coming towards pediatric seizure disorder. We have different types of seizure disorder. What are their classic features, what you're going to see in EEG electroencephalography, and what treatment you're going to offer. So we have absent seizures, we have juvenile, myoclonic epilepsy, we have simple febrile seizures, we have West syndrome or infantile spasm, we have partial seizures, and we have generalized seizures. So we have to summarize all these type of seizures. So starting with the absent seizures. Now for the absent seizures, the classic features include frequent seizures with cessation of motor activity. There will be no motor activity, there will be no speech, there will be blank facial expression and flickering of eyelids. More common in girls, rare in children less than 4 years, and rarely last longer than 30 seconds. There are no aura or post-ictal state. There will be no post-ictal state, there will be no aura before the start of the seizure, mostly involving girls and rare in children who are below 4 years of age. Now, what are the EEG finding in these children? They are the 3-second spike and generalized wave discharge. That's very important for absent seizure, generalized wave discharge and 3-second spike. Now, treatment, first line is ethoxyzumide. Alternatively, we can provide valproic acid. But remember, first choice, that is ethoxyzamide, right? Alternatively, you can give valproic acid. Now we're coming towards juvenile myoclonic epilepsy. So juvenile myoclonic epilepsy, there are jerky movement occurring in the morning, onset around adolescence. There are jerky movement occurring in the morning, especially in case of juvenile myoclonic epilepsy, and onset around adolescence will occur. And there are the irregular spike and wave pattern you are going to see on EEG. And first line you have to give here, that is valproic acid for the treatment option. So JME, juvenile myoclonic epilepsy, will give valproic acid, and there will be irregular spike in wave pattern on EEG. Now for the simple febrile seizure, there are generalized tonic-clonic seizure, generalized tonic plus clonic seizure for less than 10 minutes duration occurring with a rapid onset high fever. So there will be rapid onset high fever, and then you will see generalized tonic and clonic seizure for less than 10 minutes. In a child aged 9 months to 5 years, below 5 years, 9 to 5 years, 9 months to 5 years, usually positive family history will be there, and there are no increased risk of epilepsy in this case because they are just simple febrile seizures. They are not considered to be epilepsy. You have to evaluate for meningitis, and you have to control fever in these patients. Then we have West syndrome, that is infantile spasms. Infantile spasm during the first year of life, clusters of mixed, flexor, extensor spasm will be there of trunk and extremities. So the flexor extensor of the trunk and flexor extensor of the extremities, they are involved here with infantile spasm. It means up to 1 year during the first year of life with brief interval between spasms. So there are intervals in between a spasm, you will see. And 75% have an underlying CNS disorder. There must be something underlying related to CNS. Down syndrome is most common associated syndrome here. Now on EEG, there are hyposarrhythmia, very high voltage, hypsarrhythmia actually, very high voltage, slow waves, irregularly interspersed with spikes and sharp waves. So you'll see very high voltage, slow waves, irregularly interspersed with spikes and sharp waves. So slow plus sharp waves, very high voltage on EEG you're going to see in case of West syndrome. First line, you will give ACTH, you can give prednisone or vigabatrin, pyridoxine, vitamin B6. Pyridoxine is actually vitamin B6, right? So you can give ACTH, prednisone, vigabatrin, and pyridoxine for the treatment of West syndrome. That is also called infantile spasms. Now, partial seizure. Partial seizure, we have simple and we have generalized. So in case of simple, there are tonic or clonic movements involving mostly of the neck, most of the face, neck and extremities. So face, neck and extremities are involved in tonic-clonic movement and lasting 10 to 20 seconds. No post-extal period, no, nothing in partial seizure. But further generalized, it includes impaired consciousness. In generalized partial seizure, we will see impaired consciousness. That's an important point to remember. Impaired consciousness, where in generalized partial seizure. You will see spike and sharp waves or multifocal spikes on EEG if it's a case of partial seizure. And first line you have to give is carbamazepine and valproic acid. So carbamazepine and valproic acid for the partial seizure. What are the waves pattern on especially in case of EEG of partial seizure, with the spike and sharp waves or multifocal spikes. Now we are coming towards generalized seizure. Generalized seizure, the very important finding, they are always present with aura. There must be aura before starting. There must be loss of consciousness. There must be eyes roll back, tonic contraction, apnea, no breathing, then clonic rhythmic contractions alternating with the relaxation of all muscle groups, tongue biting, very particular, loss of bladder control, prominent post-ictal state. So there is prominent post-ictal state in these patients and there is aura in these patients. Now on EEG, this anterior temporal lobe shows sharp waves of focal spikes. So here focal spikes are there, and who shows? Anterior temporal lobe shows. Now the first line, valproic acid. For the generalized, you have valproic acid. For the partial, you have valproic acid. For which one? This juvenile myoclonic, you have valproic acid, right? And for absent seizure also. So absent, juvenile, this one, and this partial seizure and generalized seizure, you have valproic acid for treatment. All right. Then we have vitamin deficiency. Is very interesting and very easy to remember. We have vitamin A, B are divided into many like B1, B2, B3, B5, B6, and then we have B9, B12, right? We have vitamin C, D, K. Some are fat soluble, some are water soluble. So actually A, D, E, K are fat soluble. Vitamin B and vitamin C, they are water soluble. So vitamin A, findings in deficiency. If your baby is deficient in vitamin A, must be having poor night vision, and there is associated hypoparathyroidism in that particular baby. But if there is toxicity of that vitamin A, that is hypervitaminosis, we can see pseudotumor cerebri and we can see hyperparathyroidism in that particular patient. So findings in toxicity will be hyperparathyroidism and findings in deficiency will be hypoparathyroidism, right? It's important to remember. Vitamin B1, that's also known as thiamine. So if it's deficient, it can cause beriberi. It's a water-soluble vitamin. It can cause beriberi and it can cause Wernicke's encephalopathy, especially in alcoholics. And if there is toxicity, usually water-soluble vitamins, they don't cause toxicity. Why? Because they are water-soluble, therefore no toxicity. Vitamin B2, also known as riboflavin, and that deficiency can lead to angular chelosis, stomatitis or glossitis. They usually link to the stoma, to the mouth, and of course, if it's water-soluble, it will show no toxicity. Vitamin B3, that's also known as niacin, it can cause pellagra. And pellagra, we have 4 Ds. What are these 4 Ds? Number 1, diarrhea. Number 2, dermatitis. Number 3, dementia. Number 4, death. So diarrhea, dermatitis, dementia, death, they are very specific for vitamin B3 deficiency. And of course, they are water soluble, so there will be no toxicity. Vitamin B5, also known as pantothenic acid, its deficiency can cause burning feet syndrome. So that's very important for vitamin B5. But of course, it's water soluble, there will be no toxicity. Vitamin B6, very famous one, also known as pyridoxine. It can cause peripheral neuropathy, must be given with isoniazid. That is very important because isoniazid can cause its deficiency because it interferes with its metabolism, with its performance, right? So we have to give vitamin B6 whenever you are prescribing INH. Because it's water soluble, it will cause no toxicity. Vitamin B9, also known as folate. So deficiency can cause megaloblastic anemia or hypersegmented neutrophils. Folate, megaloblastic anemia, because folic acid is a very important part of hemoglobin. It's water soluble, so there will be no toxicity. Vitamin B12, that is also known as cyanocobalamin, right? So it can also cause megaloblastic anemia. There will be hypersegmented neutrophils also. But there is also one more thing, that is peripheral neuropathy of dorsal column tract. Just give me a second. Okay. So vitamin B12, cyanocobalamin, that can cause megaloblastic anemia, hypersegmented, just like vitamin B9, but it has one more important thing, that is peripheral neuropathy of dorsal column tracts. And for this, the patient must be present with peripheral neuropathy if there is deficiency, right? So we have to give vitamin B12 injections to that patient if they're presenting with peripheral neuropathy symptoms. It's water soluble, there will be no toxicity. Vitamin C can cause scurvy. Its deficiency can cause scurvy, that's chymosis, bleeding gums, and petechial rashes. That's very common. And it's water soluble, there will be no toxicity. Vitamin D can cause rickets in children and osteomalacia in adults, right? And its deficiency, of course, and as it's fat soluble, so hypervitaminosis can lead to hypercalcemia, can lead to polyuria, can lead to polydipsia. So polydipsia, when there is excessive thirst, there will be excessive urine also, right? So polyuria, polydipsia together, and hypercalcemia if there is hypervitaminosis of vitamin D. Then we have vitamin K. Vitamin K increased prothrombin time. INR is increased. Signs and symptoms of mild to severe bleeding. Vitamin K deficiency can cause hemorrhagic diseases in newborn, analogous to warfarin therapy. So of course, it's a fat soluble, so toxicity is rare, and an upper limit has not been established. So hypervitaminosis of this can cause toxicity, but that is very, very rare. Alright, now we're coming towards glycogen storage diseases. We have different type of glycogen storage diseases. Quickly we'll do this. And there's some Vaughan case disease, or Pompe disease, or Curry's lactic acidosis, Anderson disease, McArdle disease. So what are the enzymes basically involved in these diseases? Like Vaughan case is caused by glucose 6-phosphatase deficiency. It can affect liver, it can affect kidney, and the clinical manifestations will be ketotic hypoglycemia. The baby is presenting with hypoglycemia, and that will be ketotic 1. And there will be, because liver involved, there will be hepatomegaly. For the diagnostic testing, of course, liver is involved. We'll go for the liver biopsy, and we will do DNA testing in this case. Treatment is, we can provide cornstarch therapy, allopurinol we are going to give, granulocyte colony-stimulating factors, that is GCSF we have to give, that's granulocyte colony-stimulating factor for the treatment. Just do rough off this, okay? They're not very much important, but sometimes they do ask about the enzyme. Then Pompe's disease, lysosomal acid maltase deficiency. It's actually a deficiency of this enzyme. All organs are involved. There will be floppy baby, hypertonic baby, the hypertrophic cardiomyopathy. This is important. Hypertrophic cardiomyopathy associated with Pompe's disease, which is a glycogen storage disease, because the enzyme, that's lysosomal acid maltase, is deficient here. It can cause floppy baby, right? And hypertrophic cardiomyopathy. Muscle or liver enzyme assay, we have to do diagnostic testing and DNA testing also. In this case, DNA testing will do an all, right? And of course, we can replace enzyme. Then we have Cory's lactic acidosis, that is actually caused by debranching enzyme deficiency, muscle and liver especially involved. This is important. And it can involve liver, so hepatomegaly will be there, and hypoglycemia will be there. So you will do the biopsy of these particular organ, muscle and liver which are involved, and for the treatment option you will provide high protein diet, and you even can go for liver transplantation, which we usually don't go for that. Then we have Anderson. Anderson caused by glycogen branching enzyme deficiency. The branching enzyme, Cory's will debranching enzyme deficiency. Liver and spleen are involved here, and clinical manifestation will be cirrhosis of the liver and liver failure by age 2. So by age 2, there will be liver failure, there will be cirrhosis of the liver. Very dangerous one. So we'll go for the liver biopsy, we'll go for the DNA testing, and of course, we have to go for the liver transplantation in that case. McArdle, muscle phosphorylase deficiency. So M for muscle, M for Mac. So McArdle, muscle phosphorylase deficiency. Of course, muscles are involved, all 3 mm, easy, right? And for the diagnostic testing also is muscle enzyme assay. 4 mm here. And DNA testing, we will go DNA testing for every glycogen storage disease. The baby must be presenting with fatigability. There is limited physical activity, and of course, for the treatment, we'll go for sucrose prior to strenuous activity. Whenever there is heavy physical exercise, you will give sucrose prior to that. All right. Now, the last topic of this PEDS section is child abuse. Child abuse may be broadly defined as injury inflicted upon a child by a parent or a caretaker without intervention. Abused children are highly likely to be maltreated again and are at increased risk for death. So it's very important to diagnose them, to treat them. Diagnostic testing, we have lab test, we have PT, APTT testing, platelet, you can go for bleeding time, you will check CBC, you will go for the skeletal survey. Why we are going for the skeletal survey? Because there are severe injuries. Even without neurological signs, there are severe injuries because of the abuse, right? Head CT scan, you will go for that CT scan, you can go for the MRI of the brain, you can go for the ophthalmology examination. If there is abdominal trauma, you have to assess urine and stool for blood. You will go for the liver and pancreatic enzyme testing. You go and do abdominal CT scan if there is abdominal trauma. Urine toxicology screen, especially if the case described there, if there is any altered mental status, go and check the urine. Why? Because there must be something mixed in the milk or in the food that can cause altered mental status, and that will definitely come up in urine. So you can go for the urine toxicology screen as well. Now for the treatment, the first step is always to address medical and or surgical issues, then report any child suspected of being abused or neglected to Child Protective Services. See, this is a favorite question. It's a very important point. You always report a child abuse case to Child Protective Services. Initial action includes a phone report. In most states, a written report is then required within 48 hours. Not for our Asian countries, but for the US. Now, the following are indications for hospitalization. If there is any medical condition requires that, go for the hospitalization. If diagnosis is unclear, do hospitalize the baby. If there is no alternative safe place, do hospitalize the baby. If parents refuse hospitalization or treatment, the physician must get an emergency court order, because this is abuse case, right? So you must explain to the parent why an inflicted injury is suspected abuse, that you are legally obligated to report it, that you have made a referral to protect the child, and that a Child Protective Services worker, a law enforcement officer, will be involved. So that is important to point out the parents as well. Alright, there is one more chart to cover, and that is lysosomal storage diseases. Okay, no problem, we'll do it quickly. Lysosomal storage diseases, we have Tay-Sachs disease, we have Gaucher's disease, we have Krabbe disease, Fabry disease, Niemann-Pick disease, and metachromatic leukodystrophy. Okay, now what are the defective enzymes here? Just like the glycogen storage diseases, we have some lysosomal storage diseases in which lysosomal enzymes are deficient. So in Tay-Sachs, this is hexosaminidase A, which is deficient here. The inheritance pattern is autosomal recessive disease. Chromosome 15 chromosome actually involved here in this inheritance pattern. So autosomal recessive. Now in this chart, you only need to memorize that they are the autosomal recessive or they are the X-linked recessive. So all are autosomal recessive except one, that is this one, Fabry disease. Only Fabry disease is X-linked recessive, rather all are autosomal recessive. So accumulated substance here in the case of Tay-Sachs is ganglioside, and clinical findings are very important. There is a cherry red macula, baby is mentally retarded, and developmental delay you are going to see in your baby. Death by the age of 2 years, that's important here. Seizure, baby must be presenting with seizure. Lysosome with onion skin, whorled membrane. So lysosome with onion skin, this is the important finding in Tay-Sachs disease. Gaucher's disease. Gaucher disease, it's most common of all. So this we have to make a note. That's most common of all, caused by which lysosomal enzyme deficiency? It's a beta glucocerebrosidase deficiency, which is actually there in chromosome 1 inheritance pattern. It's an autosomal recessive. So all are autosomal recessive except one, that is Fabry disease. Now accumulated substance here is glucocerebroside. So this is important for memorizing, that ganglioside for Tay-Sachs, ganglioside is the one which is accumulated in Tay-Sachs, and glucocerebroside is the one which is accumulated in Gaucher's disease. And the baby is presenting with hepatosplenomegaly. There will be aseptic necrosis of femur. There are the lytic lesions. Gaucher cells are there in the Gaucher disease, and these are nothing but the macrophages that look like crumpled paper due to fibrillary cytoplasm. So these macrophages, which are known as Gaucher cells, they are present in the Gaucher disease, right? It's important. Then we have Krabbe disease. Krabbe disease is galactocerebrosidase, caused by galactocerebrosidase. This is autosomal recessive disorder like all. So the name indicates galactocerebrosidase is deficient. So of course the one, see, this galactocerebrosidase is deficient. That's why the accumulation of galactocerebroside will be there, and it can cause optic atrophy and developmental delay. So optic atrophy, the word optic atrophy is particular for Krabbe disease, and Krabbe is the one which is autosomally recessive transmission is there. Now Fabry, which is the except one, which is X-linked recessive here in whole lysosomal storage diseases. Alpha glucosidase A is deficient here, and because of that ceramide trihexoside is accumulated, and it can cause peripheral neuropathy, burning pain of hands and feet. So this is important. Burning pain, peripheral neuropathy. Peripheral neuropathy is because of Fabry disease. It's an X-linked recessive disorder. Niemann-Pick disease is caused by deficiency of which lysosomal enzyme? Sphingomyelinase. It's an autosomal recessive disease on which chromosome? Chromosome 11. Sphingomyelin, because sphingomyelin is deficient, so sphingomyelin will be accumulated. It can cause cherry red macular, it can cause neurodegeneration, hepatosplenomegaly will be there, and foam cells. So these are important. Gaucher cells in the Gaucher disease and foam cells in the Niemann-Pick disease. So foam cells are the foamy vacuolated macrophages. So these cells are nothing but the macrophages. But the macrophages in the marrow, appearance is just like a foam thing, foam vacuolated thing. So these are the foam cells, right? Then we have metachromatic leukodystrophy. Metachromatic leukodystrophy caused by the deficiency of which lysosomal enzyme? This is aryl sulfatase A. And again, it's an autosomal recessive disease. All are autosomal recessive except Fabry, right? Must remember. Now, cerebroside sulfate is accumulated here because of the deficiency of this aryl sulfatase A enzyme, and as a result, the baby is presenting with demyelination with ataxia and dementia. So, ataxia, dementia because of demyelination. That is all about the lysosomal storage diseases. So don't need to worry about to memorize every point here. Just go for the accumulating substances, and this one thing, autosomal X-linked recessive is the one Fabry disease, right? And these accumulated points, right? Thank you so much. So this is the end of pediatric session finally. Thank you.